group from PATH. We have Mercy, Ranju, and Rose. And so they'll be running a session on methods in HPV and malaria costing studies. Over to you guys.
Thanks so much, Flavie, for that introduction, and thanks everyone for staying for our session. So as mentioned, my name is Mercy Mvundura, and I will just quickly start by giving you an overview of what we're going to do for this session. Basically, the objective of this session is to share lessons learned from two different studies that we led, which were multi-country costing studies evaluating HPV vaccine program and then also malaria vaccine delivery program. So what we'll do is we'll start off with just giving you an overview of the two studies so that we provide some context for what we're going to talk about as we discuss some key things. And then what we'll do is, so I'll present on the HPV cost of delivery study, then Ranju will present on the malaria vaccine delivery program that she costed. And then we'll do just a panel discussion where we'll cover lessons learned from different stages of the studies, focusing on pre-data collection, what we did for data collection, and then post-data collection. And then at the end, we'll have a Q&A session where we'll just open. You know, a lot of you have a ton of experience doing similar work, so let's share experiences, lessons learned, really for as we think about next studies. And then also we'll open for discussions and questions to us. Next, I'll move to the next slide. And so basically what is out of scope is presentation of study results. The RTSS malaria vaccine costing study, which Ranju will talk about, is already, the studies are published, one in PLOS ONE, one in vaccine. Rose and I worked on the HPV vaccine cost of delivery study, plugging in for our presentation on Tuesday, 3:30 to 5. It's a tough slot. I will tell you, there's so much going on during that time, but if you're interested in our results, we have quite interesting presentation looking at just the results from the study, and just looking at the topics that we cover. There is, again, the 6-country study results, looking at deep down into service delivery. How do service delivery strategies impact the cost estimates? HPV, thinking about single dose presentation, what is the cost implication of moving to a single dose presentation? And then finally, the last piece is Senegal. We looked at the cost for 2019 and then for 2020. So what was the impact of the pandemic on HPV vaccine delivery costs? So it will be an interesting session, but again, not just putting in a shameless plug in. So now just quickly looking at the overview of the HPV vaccine cost of delivery study program, which again, Rose and I will focus on, and we also have our colleague Teddy in the back, who will be part of the session on Tuesday. So basically why we did this study was really, when you look at most prior studies for HPV vaccine cost of delivery, these were done either at introduction or pilot phases. And so really those studies show generally higher costs. So we sought to estimate the ongoing costs to deliver HPV vaccines in national programs that are beyond the introduction stage. So this actually was a combined costing study with an operational context study. And so that work was done in Ethiopia, in Guyana, in Rwanda, Senegal, Sri Lanka, and Uganda. So we had 6 countries. We used ingredients-based micro-costing methods combined with operational research methods, and did retrospective costing, focused on 2019 as the reference period for our study. And this was really trying to, except for Senegal, focus on a pre-pandemic period. So data collection was done using structured electronic costing questionnaires or programmed in ODK, and we'll talk about lessons learned from that. And then data analysis was done using Stata. So in terms of the sample selection, we actually used a 2-step process. The first was a criteria-based purposive selection of the regions in each of the study countries that we're going to use. And then we did stratified random sampling of subnational administrative offices and health offices. We used actually their sample design optimizer tool. And thanks to Stephen for the support as we worked through that process. And again, that is a tool that is available on the Immunization Economics page for just improving the methods for sample selection for costing studies. So we did data collection at each level of the health system, and our sample sizes for the study countries are shown in the table there. So what I'll do right now is hand over to Ranju again, so that she can provide context for the malaria vaccine costing work. Then we'll go into our panel discussion. Thanks.
Thank you, Mercy. So just for the context around the malaria vaccine implementation program, in 2016, the World Health Organization, WHO, actually recommended pilot implementation of the RTSS malaria vaccine in selected areas of the sub-Saharan Africa. So 3 countries, Kenya, Ghana, and Malawi, were then, were selected to implement this program, and they actually began pilot implementation in the subnational selected region as a evaluation, program in 2019. And this MVIP, or the Malaria Vaccine Implementation Program, was a very coordinated evaluation effort that was led by WHO, along with many partners, including the country partners, the global level, the academic researchers, et cetera, et cetera. So it was a big coordinated evaluation effort. And the objective of the MVIP as such were threefold. First, to assess the safety of the vaccine. Second, the impact of the vaccine, impact on the mortality and severe diseases of malaria in children. And third was to determine the operational feasibility of implementation within the routine immunization program. And the costing work falls under this operational feasibility, where we were attempting to generate evidence around the economic, feasibility of the vaccine rollout moving forward. So and the reason that was important to just, do the costing was because RTSS was recommended as a 4-dose vaccine, which is quite a bit of number of vaccines, requiring some additional, touch points or for children to come and for the vaccination, as well as the 4th dose was delivered in around 24 months, which is not a typical time when the children gets vaccinated. So it was important to understand, how much extra, a cost it would cost for the program to sort of deliver that vaccine. Two separate costing studies were done within this project. One was the prospective costing, and the second, the retrospective costing. And the objective, or the questions that each of these were asking, was slightly different, though related. In the prospective analysis, our question that we were asking is, like, we were starting at the end of the MVIP and asking, like, now for the MVIP, there is a support from the external, bodies for the financial, running of the program. But once the support or the MVIP program ends, how much would it cost the countries to continue to vaccinate children within the MVIP areas or the pilot implementation areas? So that was the main question that we're trying to answer with that, the first study. And then the second one, the retrospective costing, with that study, we wanted to understand, actually, now that the program is implemented, how much did it actually cost to deliver the program? So those were the 2 different objectives leading to different methods that we used. And in both of those analysis, we used an incremental cost approach, and was done we used an activity-based, ingredient-based activity costing, which we'll discuss later as well. And that, although the program was supported, especially for the MVIP, the retrospective costing, was supported from the external, funding agencies, we wanted to cost it from the government's perspective to understand, the potential financial implications moving forward as well. So it was done from the government's perspective, and we did both the financial and the economic, cost estimates were generated. With regard to the data collection and sampling, for the prospective costing, most of the data were collected from the national level with the direct interaction with the program planners, managers, to sort of understand what activities they would do post, support ending of the MVIP, and with some, purposely selected health facility visits and at different levels to sort of gain more of a contextual information to support the costing analysis. For the retrospective costing, we actually did use the actual expenditure data from the that was spent on the MVIP from different sources, that because there were like multiple sources of expenditures, and we also use the actual output, which is the coverage and et cetera, that we observed. So those were the major differences there. And yeah, I think that is in a nutshell. We won't go into the results or anything, but that's just the brief introduction to the study.
All right, so we're just going to pivot into talking about pre-data collection, data collection, and post-data collection as kind of three main stages to just have a panel discussion about main lessons learned. And I want to stay on that slide. So I'll start with Ranju. You mentioned, so there's two costing studies for RTSS, one using prospective data collection, one using retrospective. Can you just unpack that a little more and the trade-offs you faced when looking at making that decision for your methodologies?
So the main, the decision choice to use the prospective versus the retrospective were based on the two main criteria. So one is the research question: what is it that we are asking, and what data? And the second is what data is available currently to answer those questions. So as I mentioned, for the prospective, the question that we were asking is like, post MVIP, what would it take the governments to continue the vaccination in that pilot area so that they can, help make decisions around the continuing vaccination and perhaps the future rollout of the vaccines, and what data was available at the time. And just to mention the timeline, we did the prospective costing, it began in 2017, and then the retrospective, because the pilot wasn't implemented, they didn't start vaccination until 2019. We waited until 2019, 2020 to sort of do the data collection. So given the data availability, limited data, no data availability around the actual implementation, we had to do the cost projections. The good thing that we had for this, for the MVIP, and it might be unique to this particular situation, is that the implementation programs, the implementation, what do you call the plans were actually being very rigorously being developed and were available for us to sort of use as a starting point, and then make amendments to those, sitting again in with the country planners, etc., to sort of make amendments and adjustments. So we had that as a starting point there, so that was an advantage, definitely. But then we had to think around, what would you do now that, okay, what specific activities would be needed moving forward, not just, from the pilot perspective, but, as we think about the routine vaccine delivery, etc. as well. One trade-off, I think a lot of lessons learned that was discussed in the previous session, it was like, all applies, most of it, and all applies to our session, these programs as well. We do face, when we talk with especially in the prospective analysis, it's kind of hypothetical, in the sense that we want the program planners in the country, we work very closely with them, and having to think through the hypothetical product, and then think about the activities. It can be, we run into these questions around, okay, do we do it normatively, or, how do we do it? So that is kind of a challenge, but then I think, finding the right people, like right planning people for each of those different, categories of activities that go into that would be an important point there. In terms of the retrospective, I think, it is more robust in the sense that we see like what was actually spent and what was actually, achieved from that. So that, the results are definitely more, robust. One thing that we faced in terms of, detangling, this MVIP was supported from different donors and then was planned to do for, success. And given that we were taking the government's perspective, we tried to sort of, detangle the pilot-specific costs so that those cost estimates could be more useful in the future. So we had done some sensitivity analysis with and without the pilot and etc. So, those were some of the, differences, if you like. Yeah.
Thank you. And Mercy, to your HPV cost of delivery study, I know there were a couple of things that played a factor in terms of the selection of the reference year, and then also you can mention more about the retrospective methodology, but could you just share more about those decisions?
Sure. Yeah. So for the HPV cost of delivery study, we did retrospective costing. The reason we chose 2019 was really trying to avoid the 2020 pandemic period, so that we would, because the point of our study was really to evaluate programs that are beyond introduction, and also just to understand the year-on-year cost for HPV vaccine delivery. So obviously we know 2020 and 2021 were unusual years, and so there were a lot of adjustments that were done to programs, and so we chose to do 2019. And for us, I think one thing as we think about retrospective costing, we are really costing what was done. There are limitations to that, in that sometimes it's cheaper not to do things, but it's not necessarily, it doesn't have any it has implications on quality. So you go into a program and they'll tell you we've not done any training, right? And so training costs are zero, which is great. It's a low cost program, but then you've not evaluated the quality piece. So we costed what was done, but obviously as we look at, and for us, that was the importance of the operational context. We didn't unfortunately include any quality measures, but at least we know we have a little bit more context of what was done, why it was done, and how frequently it was done. But I think it just helps again in the interpretation, because again, it's not about cost minimization. It's trying to reflect, what these programs should be operating. And as you also look beyond the introduction years, a lot of the cushioning that is coming from donor funding sometimes has ended, the introduction grants are ended. And so you see programs starting to adjust to taking these costs into their own budget. And so even in terms of intensity of activities have declined. Some things do continue, but again, some things tend to decline. And I think that's the reality when you're costing what is actually being done than what should be done.
So Mercy, staying with you, could you share more about how you calculated your sample sizes and the sample selection process?
Yes. So sample selection really, as mentioned, we used the sample design optimizer tool, which was really great. And one of the things, of course, determining sample size is always budget. So we had, budget for 6-country study. Ideally, we'd have wanted even a larger sample size for better precision. But again, we were able to use the tool again just to guide where would we be on the efficiency frontier, and that was super helpful. And we had, I would say, relatively large sample sizes for costing studies across the 6 countries. So that was really great to be able to have that data, and just the work that we're going to do. We have additional work going on with the data analysis, and what we're able to do with the relatively larger data sets was really important. But really, budget constraints are really what determined sample size. We tried to be representative. We didn't do nationally representative samples, but we did look at regions and try within each country context to see, there are, for instance, when we look at Guyana, their hinterlands, their coastal areas, try to represent those types of geographies within the country, then randomly sample, stratified random sample within the selected regions, again, because just of budget constraints, we couldn't do a nationally representative sample, and time constraints for data collection, the logistics and other things that we'll get into was also considerations as we're looking at sample size determination.
So once we have our methods developed, we go through IRB process. And I know a lot of times costing studies are reviewed by IRBs that are used to reviewing clinical research. So it's a little bit of a different ballgame. Ranju, could you share about, so both of these studies were multi-country. Some was considered human subjects research in some contexts. Could you share more about that, and also the implications? So how did that impact the overall project timeline?
Yeah. So it was considered a human subjects research, but low risk. And, we were able to get an exempt, at least from the, from the US IRB, where it was the general protocol was submitted. For the NVIP, given the engagement of the MOH, MOH was the integral part even in developing and, planning and all the processes. So it was more organic in that sense, that we did not had to go through, at least for the MVIP studies, through the local IRB in Malawi and in Ghana, but we had to go through that process in Kenya in particular. And then it takes some time, right? It takes a couple of months, which wasn't much of a problem for us given the timeline that we had for the data collection and when we began. So we had like 2 whole years for the data collection period as we were trying to gather data as the program was rolling out. So it wasn't much of a problem for this particular case, but that may not be the luxury for, you know, some other cases. And one thing I would say is that, you know, in general, and even in Kenya, I think what we had, you know, the feedback that we get is these protocols are being reviewed as a clinical trial. I mean, no matter how much you put an effort into, I mean, with that lens from the reviewer's side. So we need to make an extra effort to sort of, you know, explain that, you know, what it is and what it is not, because I think, you know, it hasn't been long since they have started seeing this kind of research protocols, because previous studies, you know, some of those that I'm aware did not have to go through these processes. And more recently, I think the local IRB clearance is required, and the review that we're getting is like, you know, sometimes the questions like, you know, that come from that clinical trial lens. So, you know, we need to make some extra effort, and then at times it delays further the timeline for the entire review process.
And then I'm going to move on to the next question. Yeah, and so just kind of thinking about the pre-data collection phase overall, Mercy, you were working in 6 countries. There's a lot going on in terms of preparing for training of data collectors, managing questionnaires, getting through IRB processes. From just an implementation perspective, can you share what was helpful for getting the research off the ground?
Yeah, so we were trying to coordinate this work in 6 countries, but fortunately we were able to stagger the activities with really the determination of who was ready to start. There was active engagement of ministries of health. And so as they become actively engaged, as we had IRB approvals, then we're ready to implement or to start data collection really, because since there was no real implementation, but implement the study. And so what we did was really work on generic protocols, which we then used and adapted for the different country contexts. And then also had some learnings from Rwanda was the first country where we did the data collection. And so we had generic training module for data collectors, and all of these things, unfortunately, were done remotely. There was some gathering in country, but our data collection was still in the pandemic period. And so it was hard to gather the whole study team together. And so we really had to rely on checklists and standardized documents and standardized materials. So we had a training deck, which we used for Rwanda, and then that was cascaded down to the other countries, of course, being adapted as needed for the other country context, just because we were operating in a pandemic era. So there was a lot more coordination. We had checklists. So we knew, again, from the Rwanda experience that, well, the first thing, and we'll talk about ODK later, we knew roughly how much time you needed for adjustment of like our electronic tools, then for hiring of our data collector, making sure by what time as you are preparing to do your data collection, do you need to have procured your tablets? Do you need to find a local programmer who's going to help with your ODK programming and adjustment as you are doing your piloting? So really a lot of checklists help us. So we had a ton of checklists. I mean, this project had just to keep us going. And so constantly we're meeting with the team to check in and say, where are you with this thing? Is this thing done? Do you have your venue? Do you have your logistics in place? Again, so just checklists were super helpful for coordination and management.
Right, so now over to Ranju.
Yeah, Mercy, you mentioned about, you know, a lot of using those tools and techniques to sort of make sure that the multi-country study that is happening and where you're engaged in data collection concurrently, and mostly within, you know, having to finish that within a specific, you know, short timelines. I think, you know, there goes a lot of coordination and management to ensure that, right? So what are the approaches that you took to sort of, you know, alleviate any kind of challenges that came across in the coordination and management across countries? And I think would be good. I think you touched already around the ODK. Um, were there any, challenges that you faced? In general, we spend a lot of time developing, especially in a bigger studies, a lot of time upfront developing those. But what were the specific sort of pain points and the challenges that you faced in that, for the data collection process itself?
Sure. So I mentioned we used ODK, which was great at the end, but at the beginning, I will say it was painful. Just because we had a long questionnaire, we had a lot of questions. And so we had our team in Senegal program the ODK tool, the generic one. And of course, we had a different team. The health economists and the operations research folks had created these tools on paper. Obviously, we didn't put as much detail about skip patterns. I mean, we had some skip patterns included. I mean, we had done quite a good job if you're looking at paper. But as somebody is thinking about programming this into an ODK, the details of the skip pattern and, specifying, put this in, in decimal. So we were also trying to implement a lot of quality checks so that we could leverage the full value of ODK. So that turned out to be quite the undertaking. It took us, I would say almost 3 months to get us to where we were happy with the ODK tool. And then, of course, as you move to each country, there is some adaptation that needed to be done. So you needed to find a programmer locally who could do those adaptations, make sure that as they're adapting the tool, they're also not messing up some things and skip patterns. And that was quite a challenge in some countries that, where ODK has not been used widely for data collection, especially we were dealing with more ministries of health staff. And so if they were not experienced with using electronic data collection, that was quite a point. And one other issue that we had is also our checklist. One of the lessons we learned after Rwanda, the ministry decided that they were going to donate to us some tablets to use for the study. But as we were getting ready to launch, we realized the version of ODK on the tablets was the wrong one. It was an old tablet. So we had to scramble and do a quick procurement of tablets so that, again, we could have tablets that were not, being a challenge, because the software was old. They were much older tablets, and our version of ODK was much newer. And of course, then making sure that everybody has the chargers and all the other logistics that are related. But I would say the programming is where lesson learned was we just needed a lot more time to make sure that the programming was done right. The skip patterns were working, and constantly, again, checking within each country before we actually started. We were double checking to make sure that as adaptations of the generic information about health facility names were done, that other things had not been messed up in the process. But I will say at the end, it was worth the pain, because you, again, were able to enforce, data quality issues. We didn't have to deal with data entry. We also, you could say, enter this as a decimal. So one of the things we've noticed when, data collectors are left to put things in free form is somebody will put a $sign and $10, and somebody puts a 10. And so already you've already changed the nature of that variable. So you'll have to do much more data cleaning. But in this case, if it was numerical, it was numerical. If it was accepting a decimal, it was accepting a decimal. Sometimes it was capping. This number should not be more than 200,000 or whatever, depending on the country context. So again, that just helped us at the end. But obviously, the process leading to that was quite some work.
Yeah, we didn't use ODK for the MVIP costing. We used the traditional paper-based approach, and then I can see the pain that you had up front versus the pain we have like at the back end when we're not able to do the quality control right away, and then a lot of back and forth between the data collectors and all that as time passes by. So definite pros and cons to that. So Rose, maybe to you, because given that, you had not just the costing component, but also the huge, operational side of the things that you're collecting data around, did you have any challenges around, finding the people, like the data collectors, and, were there any issues around, how did you ensure the consistency and the quality of that, consistency across different countries for the data collection? Either of you can take it.
I can start, and I'm sure Mercy can fill in the gaps. But so as mentioned, this was like two giant studies mushed together. It was an operational research study and a costing study. And so we really were looking for data collectors that had had previous experience with data collection before for either like an EPI survey or, but very few people had actually ever done costing before. So as part of our data collector training, we started off with like Health Economics 101. What is costing? What does that even mean? What are resources? What is economics? And so that was really helpful for training data collectors who had done surveys in the past, but didn't have any experience in costing or health economic evaluations. So that was one thing that we just did across the 6 countries. In terms of the data collection period itself, some helpful elements that we included were simple things like WhatsApp groups, where a pain point that one data collector is experiencing is likely a pain point that many others are experiencing. And so they could share lessons learned in real time in terms of, oh, this question, people are thinking about it this way. Is that right? No, it should be asked this way. This is about how much time did they spend on stock management only for HPV vaccine, not for other vaccines. So being able to respond in real time to those questions that came up when the survey was being deployed. I don't know, Mercy, I was very fond of electronic data collection because on ODK Central, you can actually go in and review each line entry and you can approve it, you can reject it, you can say there are issues here, and then there's a place on the back end where you can make edits in real time and have conversations, while your data collector is still in that health facility. And so I think just that connectivity the connectivity and the where the technology is now is very helpful.
Sure. Yeah, no, I think you've covered it well. What I actually want us to pivot to now so that we can have time for discussion is thinking about our data preparation. You've mentioned the joys of ODK and just wanted to learn, just maybe lessons learned from the data aggregation, the data merging process, as you think about how we handle that. Just share lessons from that piece.
Yeah, so this is a very, transparent lesson learned. So we initially didn't have a data manager hired to be on our team, and we ended up collecting, upwards of 6,000 variables at each level of the health system in 6 countries. So it's a lot of data. And in some cases, ODK was appending odd letters to the start of variable names. And so we're sort of looking at this massive amount of data and how are we going to analyze it? And so then brought on a data manager who helped kind of download, transform, and standardize the data sets. Even though we had been already working with standardized variable names, in the process of data collection, those CSV files changed and we needed someone who could give some TLC to those data sets. So that's a lesson learned for me moving forward. Any multi-country study, it's bring in a data manager, bring them in early, because this is their expertise in terms of helping teams manage large sets of data. So I think our data manager would have had advice for how we may have even structured the questionnaire a little bit differently or broken up our large data set into maybe 2 smaller, more manageable data sets. So props to data managers, bring them on early. They will help make your life easier.
Thanks, Rose. Totally agree right there. If we had brought on our data manager earlier, our data analysis would have been started much quicker. But again, it is all lessons learned and we're being transparent. Ranju, do you want to share anything on the RTSS costing study? You mentioned data entry using, you did data collection on paper. Any lesson learned as you were thinking about your data entry processes and just getting your data ready for analysis?
Yeah, I mean, we did the paper version and then it came with the standard challenges of the, the paper version, which is again, a lot of back and forth, not being able to do the quality control right away, etc. And then the good thing is that, for at least for the MVIP costing, given the timeline that we were working around was a little longer, we didn't have to suffer, the delays in timeline overall. So we were still able to sort of meet all those the deadlines. So I think from the data entry perspective, there are, the trade-offs are like, pretty standard, and yeah.
No, it's this one. Just while you have the mic, do you mind just wrapping up and letting us know about any lessons learned as you thought about data analysis or challenges you faced with data analysis, or getting some data that you needed for the analysis you targeted to do?
Yeah, for data analysis, we developed the costing tool, and Win is here, Win and Anna are here, who were the developers of the costing tool that was used for both of those analysis. So I think developing the costing tool was definitely, very useful and helpful in terms of harmonizing the analysis across 3 countries, because we wanted to be, as consistent, but wanted to be consistent across the different countries. So using the same tool and same, ensured that we were applying the same methods. Although given the nature or given the way that we had, designed the study was activity-based costing. So which means that, I think less of an analysis issue, but more of an comparative issue across the countries. I think that lead to, not, although we harmonize the methods and everything, I think the results, the outputs that you get reflect the health system capacity at the beginning, because we were doing the incremental costing. So whatever the starting point for each country is at the beginning, the cost estimates will be reflective of, the higher, meaning there might be higher introduction cost needs, etc. And which was the case in case of, for example, in this MVIP costing in particular, in Ghana, there were some, cold chain capacity needs identified to fulfill the lack of capacity in country to kickstart the program. So those were all accounted for, whereas in some other countries that was not the case. But the good thing is that given we did the activity-based costing, the results could be seen from the activity-wise, and then there would still be some comparability across that. From the analysis perspective, again, going back to the costing tool itself, it can be rigid, right? I mean, thankfully, we had WIN's support throughout the project to be able to make amendments as needed for from the prospective versus going to the retrospective analysis, because the nature of the data that is coming in is very different. So we ended up, spending a lot of time sort of, adapting the prospective module to come to, to make it fit for the retrospective module. And we didn't want it to create a separate tool, but in the hindsight, when you can speak to it, but it might even have been better splitting it into 2 different costing tools. But we had combined and then spent a lot of effort doing that too. One thing from the data analysis perspective for the MVIP costing that comes to my mind is we wanted for the MVIP to, the retrospective costing, to use the actual expenditures and actual outputs. So, and we also did it from, wanted to do it from the government's perspective. Now, given the pilot nature of the project, and on top of that, it was done as a part of the evaluation, which had other components besides the pilot implementation. So there's a lot of, we had to be very meticulous and careful about not accounting and trying to separate out the costs that were very pilot specific, specific to the pilot, and that was spent in the evaluation, because a lot of times those costs or the expenditure data comes as aggregated, and it's difficult to separate out as well. So we had to be very meticulous, and in some cases had to make assumptions to sort of distribute that too. One last thing that I would raise is related to that. We wanted to use the outcomes of the pilot, in terms of the coverage and etc. And we use the 2 years data on the outcomes as well. Now, if you look at the fourth, the children, and it's a 4-dose vaccine, and the children receiving 4th dose at the end of 2 year, many of those who had received the first 3 doses were still not age eligible to receive the 4th dose of the vaccine. So the calculation of, the fully immunized child against RTSS would be like naturally, if we use the actual coverage data, it would be sort of, overestimating the cost of the fully immunized child. So we had to, again, make assumptions about the projections of, what the trajectory looks like for the coverage to come, to make it more, more realistic, so to speak, to avoid some of those by design kind of challenges.
Thanks, Ranju. Rose, I'll close with you. Just a quick question around what we use for data analysis and any lessons about generalizability given we have a 6-country study.
Yeah, very quickly, we used data for our data analysis, which worked great because that enabled us to have do files that could then be localized for each country context. We had weekly data analysis team check-in meetings, which were also really helpful to remain aligned on assumptions and pain points, and also helped us check each other's work. We were just kind of always reviewing one another's work. Generalizability. So we did not do nationally representative sampling, and so we do not have nationally representative results, but they are representative of the regions that were purposively selected for the study. So with everything, read the methods before drawing a conclusion about how much it costs to deliver HPV around the world.
Yes, thanks so much. So we'll stop there and we'll open it, focus on questions to us if there are things we haven't covered or things we say that you will need clarity on, but also really, could we learn lessons from the 3 topics we focused on: pre-data collection, the data collection process, and the post-data collection that you've also gathered from your studies, which you think it would be great to share with this community of practice. So thanks for your attention. And I see several hands and we'll just move the mic around.
Right. So just in the interest of time, we'll do 2 rounds of questions. We'll get a few in each round. So I think is the first one over there.
Thanks so much. Ijoma Eduka, University of Witwatersrand, Johannesburg. Thanks so much for this presentation. Very useful, practical insights into some of the challenges and perhaps ways of dealing with these challenges during data collection. I have a few comments. I'll try to be very quick. So you've talked about so many things, but one question which we found in a costing study currently I'm currently involved in is how do you deal with non-responsive key informants? Because you're relying on people to give you data, and basically they're not. I mean, I suppose with the MVIP, because you already have an established program running, then you had already established links. But in the case of going into a country and doing a study without any established links, how do you deal with non-responsiveness? And I'll be interested to hear a bit more about what your results are for the prospective now with the RTSS vaccine, the prospective and retrospective data. How close were the results? Because I think we often run into this challenge of whether collecting retrospective data, and that's usually after the decision has been made to implement an intervention. So having more studies that are able to compare the 2 types of methods to a large extent can give us more confidence when we collect prospective data that it's close, it might be close enough to what will happen in practice, unless I completely misunderstood the reason why you did a prospective and retrospective data collection. And then the 3rd point I wanted to make was, how do you balance recall bias? In the HPV vaccine, you went for 2019 so that you don't model the whole impact of COVID. and, the changes in the processes, but then how do you deal with, people remembering basically what they did all those years ago, and to what extent you account for that in your costing? And then lastly, the training materials that you use for training data collectors, you've mentioned the basic, costing, health economics 101, but are these materials available? Is that something that can be shared with the community of practice? We don't have to reinvent the wheel.
Thank you very much. Interesting insights here. Frederick Luaga from Clinton Health Access Initiative. I just have two quick ones for the RTSSs. We know countries have NVI plans, at least the 3 pilot countries, they had NVI plans, but you went ahead and did a prospective sort of costing. I would like to know what your comparison from what you saw in terms of variability between NVI plans, what they had in terms of what they had costed, and what you're actually seeing from the prospective costing, and what are those activity lines that are really coming out as salient in terms of being missed out, and now you're seeing, because this is good information for countries that are going to introduce learning from the pilot countries, what things should they look out for that are really critical and being missed out. Then for HPV, quickly, because you looked at programs that are beyond introduction, from the insights that you are seeing with regard to school-based platforms, community-based platforms, and even health facility-based platforms, what are the, for example, in terms of cost effectiveness, in terms of delivery of vaccines across those different platforms? Have you looked at that, and could you share some insights around that? Thank you.
Yeah, I can start. You were right. Non-response wasn't a big issue for us because, it was, with at least for the NVIP, we had the letters from the ministries, and given our main, respondents are the government employees, and, non-response wasn't an issue. However, there might be, with regard to the responses and the, for example, I'd like to take a case of like time use. We were doing the economic valuation of their time that they were spending on different activities as well around that. And we saw a lot of variation, and we don't, and I think one of the lessons learned from that is that we might want to, moving forward, not just ask for their own time, reported time use, but have some other methods to sort of do validation of the quality of the data that we're getting. So that is one point. Around the comparability, and I think both comments ties in there. The idea, why we do prospective costing is because we do not have the data to begin with, and therefore we do the, projections of, the cost to understand, what the cost structure would look like moving forward, so that can help some decisions. In this particular case, we had resources. We wanted to, also look at not just projecting out, but what actually was spent in pilot. So we had that luxury of being able to compare that and validate the results. There were, a few differences, but overall across the country, if you look at the range, it's pretty close, and they overlap quite a bit. But, the NVIP costing, the pilot costing, we saw it was in general across the countries slightly higher than that was observed in the prospective costing. Now, you cannot, we can't necessarily compare these two studies because the purpose that we were trying to achieve was different. And the activities that were required after the pilot implementation and within that particular areas, were different as well. And the coverage or the inputs, other input assumptions that we're making on the prospective costing was based on the other vaccine, how the programs were doing for the other vaccines versus how it was done for the MVIP, the coverage levels and et cetera were widely different. So we have to be really careful in comparing, the outputs. But in general, I think, they were like, if you look at the cost structure across different activities, there is slight variation that we see between prospective and the retrospective costing, and we can compare the activity category specific cost estimates to see, how those vary as well. But in generally speaking, the MVIP costs are slightly higher in general, but still within the, across the countries, they are within the range. And your question, I think it's related to the activities and the cost, how comparable they are across the countries, right? We, as I mentioned, we did this activity-based costing, and the cost estimates that we come up with, given the nature of the methods that we use, is dependent on the capacity of the health system in the beginning. So, those do not necessarily, we can't necessarily make an apple-to-apple comparison there. But in general, when you look across the different health facilities, especially at the facility level data that we were able to gather in the retrospective analysis, on an aggregate, on an average, I think you can still make some good sort of comparison. But when it comes to, but we have to pay really clear, attention to the details of the assumptions that we're using and the specific activities. And for the activities we have listed in the publication, like what actual activities were costed and etc., differently for each of those countries, so that are available.
Thanks. We've got time for one more question over here.
Thank you very much for your presentations. I have 3 questions concerning the RTSS introduction cost. The first question is, what were the inclusion criteria of the countries in that studies? My second question is to know how representative of other African countries are the data you collected within the frame of this RTSS introduction costing. And the last one, can you tell us a bit about the results of that study and how those results are applicable for other African countries? Thank you.
Yeah, do you want to?
Before we respond, can I respond to your questions from the first round? Then Ranju can respond to yours. So I think the first question was around non-response. And for us, we had some non-response, but not too much. And so we imputed medians in that case. It was less than 5% for any particular question, and we used the median from the responses that we had. Recall bias definitely was an issue because we're looking at almost 3 years for some of the countries. But given that health workers are doing this routinely, they're going to the same schools, the same facilities, we were again, that helped. One of the main issues we got in some countries was staff transition. You get in and the person who was there in 2019 has left, and then is trying to find the senior most staff who's still around, who remembers how the program was running. But again, if in very few cases did we then just have to find another, like a proxy year to do that. But otherwise, in most of the cases, which was great, that we found a lot of the people still there. Then in terms of training materials, I think we can make those shareable. I agree, it's a resource that we've already developed, which should be able to. And then the question, I think, from Frederick on the delivery, on the results from the different strategies, that will be presented at our session on Tuesday.
To your first question, if I understand it correctly, was your question around how the control and the comparison areas were selected? Sorry. The countries or countries? I don't know if I, can go in detail. I mean, me personally, it is available. I mean, it went through that deliberate, process of country selection based on various criteria. And I think they're like all published in the WHO website somewhere. We can find it. But it looked at the criteria such as, at least some of those that I can mention here that I recall is, of course, the disease burden. Disease burden was there. The health system capacity should be able to at least, deliver those vaccines, and a bunch of, the existing strength of the health systems in those countries, and etc. But there are like many more other criteria that I cannot recall at the outset. And then because it was done to do the, the evaluation was a major component of this study. The pilot areas were completely randomized, after the selection of the areas, they were like completely randomized into intervention areas and the control areas there using the standard randomization processes. With regard to your question around applicability of these results across different countries, I think that is, I resonate with the previous sessions, comments as well. And even in this case, I think we can use this information to sort of, as a starting point to sort of, give us an idea in a rough way if the countries have similar kind of health system, are in the similar kind of economic status, etc. And we can look for other characters as well to sort of match and try to use some of these estimates across. But then very careful attention is extremely important when we try to extrapolate these results across other countries, for sure. I don't know, Mercy, do you want to add? Or any?
No, I think you've covered it well. Thanks. And I know we're coming between people and lunchtime, so you should be wrapping up.
Yeah, we can wrap that up. Thank you for that great enlightening session. So we're going to break for lunch now and meet again at 1:15 for the next session.
Thank you so much.
Thank you.